In clinical medicine, our entire training apparatus is just fundamentally geared toward the rescue.
Right, the acute intervention.
Exactly. Like you see someone drowning in a river and your instincts, your muscle memory, it all just kicks in. You jump into the water, you pull them onto the bank, you clear the airway, you start chest compressions. You are dealing with the acute crisis right in front of you.
And I mean, that focus is entirely necessary. When a patient is in acute respiratory distress from an asthma exacerbation or, presenting with severe pediatric dehydration from a diarrheal illness, you don't really stop to ponder the sociological origins of their condition.
No, of course not.
You stabilize the patient. The acute intervention is the absolute foundation of clinical practice.
But inevitably, you look up from that first successful resuscitation and you see another person floating down the river. So you pull them out, then another one, then three more, and suddenly you are exhausted, the ICU is at capacity, and the realization hits you that you cannot possibly save everyone who is washing downstream. You realize that focusing exclusively on the rescue means you're ignoring a much more terrifying reality.
The reality that someone, somewhere, is walking upstream and actively throwing these people into the river.
Exactly. And that brings us to the core of what we're doing today. Because if clinical medicine is downstream rescue, while environmental health practice is upstream engineering.
I love that framing.
Right. It is the act of walking up that riverbank, identifying who or what is throwing people in, and building a structural, systemic barrier to stop it from happening in the first place. So today, we're undertaking a comprehensive deep dive into Chapter 11.5 of the Oxford Textbook of Global Public Health, focusing entirely on environmental health practice.
And it's a dense one, but so crucial.
It really is. So if you're joining us, whether you're a medical student, a junior doctor, a public health trainee, or, an allied health professional, this is your conceptual companion to the text. We aren't here to just read bullet points at you. We're here to clarify the frameworks, strengthen your clinical reasoning, and help you recognize how the macroscopic environment dictates the microscopic pathology you see in the clinic every single day.
And that metaphor of upstream engineering, it really captures the essence of operational public health. Because environmental health practice isn't just this abstract academic discipline.
Right.
It is the rigorous and honestly often combative translation of scientific disciplines like environmental epidemiology and toxicology into a literal protective shield.
Combative is a good word for it.
Oh, absolutely. We're talking about the mechanisms required to establish enforceable legal limits,
Yep.
the logistics of rigorous inspection protocols, and the architecture of really complex surveillance systems. It's the process of taking the raw science of what makes human beings sick and converting it into the tangible infrastructure that keeps populations well.
And what I find so compelling about this specific chapter is how it forces a shift in your diagnostic perspective. Like it demands that you look beyond the immediate symptom, the wheezing, the dermatitis, the neuropathy, and trace it back to a systemic root cause.
Yeah.
But I mean, to even begin measuring a threat, we first have to define the environment we're trying to measure. Because I think a lot of people conflate environmental health with environmentalism. They think it's about saving the rainforests or protecting endangered species.
That is a very common misconception, actually. And the World Health Organization definitions, specifically from 1989 and 2004, they're quite explicit in drawing a boundary here.
Okay, how so?
Well, when we talk about environmental health in a public health context, we are looking at the physical environment, which includes both natural ecosystems and the built environment, like our cities, housing, transit systems, as well as the social and psychosocial environments.
Right.
But the critical distinction is the anthropocentric focus. Environmental health is primarily concerned with how these environments impact human health.
It's about us.
Exactly. We care about deforestation, not simply because the trees are gone, but because their absence alters infectious disease vectors, degrades local air quality, and impacts the climate stability that, our agricultural systems completely rely on. It addresses the physical, chemical, biological, and social factors that determine human quality of life.
Okay, that makes sense. And to really grasp how we arrived at this modern, highly regulated framework, we need to look at the historical genesis of the discipline. And this is a piece of history that I just find incredibly revealing about the nature of public health. We actually have to go back to the United Kingdom in 1842 to a man named Edwin Chadwick.
Chadwick is a fascinating figure because he completely upends our expectation of who drives medical breakthroughs.
Right, because he wasn't a doctor.
He was not a physician at all. He had no medical training. He was a poor law commissioner. His job was essentially that of an administrator and an accountant. He was tasked by the government with investigating the immense economic drain that poverty and poor relief were placing on the state during the height of the Industrial Revolution.
And the context of 1840s London is so crucial here. We are talking about a time before the germ theory of disease was even accepted. The prevailing medical consensus was miasma theory.
The bad air theory.
Exactly. The idea that diseases like cholera and typhus were caused by bad air emanating from rotting organic matter. So the medical establishment was largely looking in the wrong direction. But Chadwick, looking at his ledgers, saw the reality. He published his monumental report on the sanitary condition of the laboring population of Great Britain.
And what Chadwick did was essentially conduct one of the first massive observational epidemiological studies. I mean, it wouldn't have called it that, obviously.
It's really not.
But he mapped the instances of extreme poverty and the claims for poor relief directly to the physical living conditions of those populations. He documented the open sewers, the horrific overcrowding, the complete lack of clean drinking water, and he drew a conclusion that seems obvious to us now, but was revolutionary at the time.
Which was?
He established the inextricable cyclical link between poverty and health.
Right. He noticed that people were poor because they were sick, and they were sick because of their environment. It wasn't a moral failing, which, unfortunately, was a very popular belief at the time.
Still is in some circles, sadly.
True. But he showed it was an infrastructure failing. I always pictured Chadwick as like a forensic accountant curing a disease. He didn't need a microscope to see the pathogen. He just followed the money and the morbidity data and saw the exact same patterns a physician would.
And the bureaucratic outcome of that report was the 1848 Public Health Act in the UK, which is arguably the foundational document of modern environmental health practice. It created the first local boards of health and established the role of the inspector of nuisances.
What a title.
Right. But these were the direct predecessors to modern environmental health officers. Yeah. Their job was to literally walk the streets and identify the structural hazards, the overflowing cesspools, the slaughterhouse waste, and mandate their removal. Chadwick proved that you cannot have sustained economic development or eradicate poverty without first engineering a healthy environment.
So if we fast forward from Chadwick's squalid 1840s London to the present day, the macro-level global trends paint a picture of undeniable, almost miraculous progress.
Yes, on a macro level, absolutely.
Right. We have seen unprecedented wealth creation globally. The textbook highlights that from 1970 to 2010, global male life expectancy jumped from 56.4 years to 67.5 years. That is more than a decade of life added to the global average in a single generation. Furthermore, child mortality, the death rate of children under 5, has plummeted by nearly 60% since 1970.
Those are massive wins.
They are. So I have to play devil's advocate here for a second. If global wealth is up and life expectancy is up and child mortality is down so drastically, haven't we essentially solved the Chadwick problem? Like, why is environmental health still framed as a massive ongoing crisis?
It's a great question. And it's a paradox that trips up a lot of people when they only look at aggregated global data. Yes, the averages look fantastic. We are winning certain battles, particularly against vaccine-preventable diseases and basic malnutrition in many regions. But those global averages mask extreme, highly localized, and increasingly entrenched disparities.
So the wealth isn't distributed evenly, and neither is the health.
Precisely. Despite the macroeconomic progress, roughly 1 in 5 people globally still live in extreme poverty, surviving on $1.25 a day or less. Furthermore, the global population is expanding rapidly. We're adding tens of millions of people a year, and we're undergoing the most dramatic demographic shift in human history: hyper-urbanization.
Right, everyone moving to the cities.
Exactly. By 2030, an estimated 60% of the world's population will live in urban areas. And in the developing world, this urbanization is happening much faster than the infrastructure can handle. So while we currently have about 1 billion people living in informal settlements or slum-like conditions, that number is projected to double.
Wow. That is a staggering projection. 2 billion people living in slums by 2030. So for a massive segment of the human population, the physical environment they inhabit is actually deteriorating, even as the global GDP climbs.
And this reality introduces one of the most critical conceptual frameworks in the text: the double burden of disease, which is sometimes expanded to the triple burden. It uniquely afflicts populations in developing and rapidly industrializing nations.
I want to spend some time exploring this because understanding the double burden is essential for any clinician working in global health. What does this actually look like on the ground?
To understand it, you really have to imagine the lived experience of a family in a rapidly growing peri-urban informal settlement, perhaps in Dhaka or Lagos or Mumbai. On one hand, they are dealing with the traditional environmental risks.
The Chadwick risks.
Exactly. These are the risks intimately associated with extreme poverty and underdevelopment. We're talking about water sources contaminated with fecal coliforms, a complete lack of improved sanitation facilities, and profoundly dangerous indoor air pollution because the family relies on solid biomass fuels like wood, charcoal, or animal dung to cook their meals inside a poorly ventilated home. That is the first burden, the diseases of poverty.
Right, so the clinician in that setting is seeing pediatric diarrhea from the water and severe acute respiratory infections from the indoor smoke.
Exactly. But because their city is simultaneously undergoing rapid, often completely unregulated industrialization, they walk out of their home and immediately face the modern environmental risks.
The second burden.
Yes, they are breathing in severe urban smog from dense traffic and industrial emissions. The local waterways might be tainted not just by raw sewage, but by heavy metals from local manufacturing or runoff from agricultural pesticides.
So they are carrying the morbidity of the 19th century and the 21st century at the exact same time. The traditional risks of underdevelopment and the modern risks of unregulated development are just overlapping perfectly.
And this brings us to a really important differentiation that the textbook makes regarding how environmental burdens scale with wealth. It is crucial to distinguish between local environmental burdens and global environmental burdens.
Let's break that down because it is pretty counterintuitive at first glance. I mean, we usually assume that as a population gets richer, their environment gets cleaner.
And that is true, but only for the local, traditional risks. As household income rises, people buy clean-burning gas or electric stoves, eliminating the indoor biomass smoke. Municipalities build water treatment plants and lay down sewer lines. The immediate localized health burdens decrease significantly.
Okay, so what's the catch?
The catch is that new wealth is inextricably linked to higher consumption patterns. Richer populations use vastly more energy, drive more vehicles, consume more manufactured goods, and generate exponentially more waste.
So while their local neighborhood gets cleaner, their overall environmental footprint expands drastically.
Yes, the global environmental burdens, things like massive carbon dioxide emissions driving climate change, severe resource depletion, ocean acidification, and systemic ecological degradation, those actually increase as a population's wealth increases. And the cruel irony of public health is the displacement of that risk.
The people creating the problem aren't the ones feeling it first.
Exactly. The global risks created by wealthy nations become diffuse and delayed, and the catastrophic impacts like extreme weather events, rising sea levels, and shifting infectious disease vectors disproportionately affect the poorest populations who lack the infrastructure to adapt.
It truly is a triple threat for the world's poorest. They suffer the immediate local risks of poverty, the modern local risks of unregulated industry, and the delayed global risks of a changing climate driven by the wealthy.
Which means we need to transition our focus from the macro-level burdens to the micro-level realities. We need to decode the threat matrix. We know the environment is hazardous, but we must establish exactly how these environments translate into specific clinical outcomes in vulnerable individuals.
Let's ground this in the raw epidemiology provided by the text, because the scale of the threat is immense. It is estimated that a full 25% of the global disease burden is directly attributable to environmental factors.
That's massive.
1/4 of all human disease across the board is tied to the environment.
And when you look at pediatric populations, the numbers are even more severe. For children aged 0 to 14, 36% of their entire disease burden is environmentally driven. More than a third.
Wait, really? More than a third of all illness in children is just from their environment?
Yes, and when we look at mortality, it gets darker. The top killers of children under 5 are pneumonia and diarrhea, which together account for 29% of deaths in that age group. And both of those conditions are overwhelmingly tied to environmental deficits.
Yeah, the water statistics alone are horrifying. The text notes that hundreds of millions lack access to an improved drinking water source. 2.5 billion people lack access to improved sanitation, and over 1 billion people are still forced to practice open defecation.
It's a tragedy of infrastructure.
It really is. And you do not need a complex epidemiological model to connect a lack of sanitation to pediatric diarrheal mortality. It is a direct, brutal line of causality.
Similarly, the pneumonia mortality is heavily driven by that traditional risk we discussed. Household air pollution from solid fuels. Over 3 billion people rely on these fuels. The particulate matter generated in those homes profoundly degrades the respiratory immune defenses of young children, making them highly susceptible to fatal pneumonias.
But, from a clinical perspective, identifying an exposure isn't always that clean or singular. When I see a patient, I'm rarely dealing with a pristine, isolated exposure to just one chemical. How does environmental health practice manage the reality of multifactorial exposures?
It is arguably one of the most difficult challenges in the entire field. Our regulatory systems are largely designed to evaluate and regulate substances one at a time. We study chemical A, we find its safe limit, we write a rule.
Right.
But humans live in a chemical soup. A single community might be simultaneously exposed to agricultural pesticide runoff in their water, industrial particulate matter in their air, and heavy metals in their soil.
So mechanically, how do these multiple exposures interact within the human body? Do they just add up? Like, if chemical A causes 2 units of litter damage and chemical B causes 3 units, do you just get 5 units of damage?
Sometimes, yes, that has created an additive effect. The combined harm is simply the sum of their individual toxicities, but what keeps toxicologists awake at night are synergistic or multiplicative effects. This occurs when 2 exposures interact biologically to create a combined effect that is vastly greater than the sum of their parts.
The classic textbook example here is the interplay between asbestos exposure and smoking, right?
It is the perfect illustration. If you look at a baseline population, a non-smoker who is never exposed to asbestos has a very low baseline risk of developing lung cancer. If that person becomes an asbestos worker, their risk of lung cancer increases significantly due to the microscopic fibers scarring the lung tissue. Separately, if a person smokes cigarettes, their risk of lung cancer also increases significantly due to the carcinogens in the smoke.
But if you have an asbestos worker who also smokes a pack a day,
The risk doesn't just add together, it multiplies exponentially. The mechanical scarring from the asbestos fibers somehow synergizes with the chemical carcinogens in the tobacco smoke, drastically accelerating the oncological process. Their risk of lung cancer is dozens of times higher than the baseline, and trying to regulate or establish liability for a synergistic exposure is a legal and scientific nightmare.
wow. And the complexity doesn't stop at the mixture of the exposures. It extends to the immense variability of the human beings exposed. We noted earlier that 30% of the pediatric disease burden is environmental. Why is that? Why are children so disproportionately vulnerable compared to healthy adults standing in the exact same environment?
It is a critical error to view children merely as little adults. Their vulnerability is fundamentally rooted in both their unique physiology and their behavior. Physiologically, children are in a state of rapid growth, which requires an incredibly high metabolic rate. Consequently, their minute ventilation, the amount of air they breathe per minute relative to their body mass, is much higher than in adults. They also consume more water and food per kilogram of body weight.
Let me make sure I'm translating the pharmacokinetics of this correctly. If an adult and a child are sitting in the same room, breathing the same air with the same concentration of a pollutant, the child is essentially acting as a more powerful vacuum, drawing a physically larger dose of that pollutant into their systemic circulation relative to their size.
That is exactly right. They receive a much higher functional dose. Furthermore, their internal physiological systems are immature. Their hepatic enzyme pathways, like the cytochrome P450 system, which is responsible for detoxifying many chemicals, may not be fully developed. Their blood-brain barrier is more permeable, allowing neurotoxins like lead or mercury to cross over and cause irreversible damage to a rapidly developing central nervous system.
And then you factor in the behavioral differences.
Yes, behavioral exposure pathways are huge. Toddlers explore the world through hand-to-mouth behaviors. They are constantly touching surfaces and putting their hands in their mouths. And, importantly, they live their lives much closer to the ground.
Which matters because of gravity.
Exactly. Many heavy environmental toxins like lead dust from old paint or certain agricultural pesticide residues, they settle on the floor or in the soil. So while an adult is breathing the air 5 or 6 feet off the ground, the toddler is literally crawling through the highest concentration zone of the settled toxin, getting it on their hands and ingesting it. It is a perfect storm for maximizing exposure.
That's terrifying. And it is vital to remember that vulnerability isn't limited to children. The textbook highlights that the elderly face heightened risks because their renal and hepatic clearance mechanisms naturally slow down with age, meaning toxins remain in their systemic circulation longer. Women also face highly specific vulnerabilities, particularly regarding reproductive health. During pregnancy, altered maternal metabolism changes the pharmacokinetics of toxin processing, which can expose the developing fetus.
There is also a fascinating and, frankly, terrifying mechanism regarding bone metabolism. Toxins like lead are often sequestered and stored in the bone matrix, where they can sit dormant for decades. But during menopause or even during pregnancy, when bone turnover increases and calcium is mobilized, those stored heavy metals can be suddenly released back into the bloodstream, causing an acute internal exposure long after the external environmental source is gone.
Which raises a profound operational challenge. We sit in the clinic and we tell our patients, limit your exposure to these triggers. But in a world filled with synergistic chemical mixtures, invisible particulate matter, and internal toxic reservoirs, how do we even begin to quantify what the exposure actually is? If we can't see it, how do we prove it is causing the disease?
That is the transition point from clinical observation to scientific investigation. To build an upstream barrier, to enact a regulation that will hold up in court, we have to definitively prove the causal link between the invisible environment and the very visible disease. And for that, environmental health practice relies on its two primary scientific engines, epidemiology and toxicology. Let's look at the detectives.
Let's start with epidemiology. In the simplest terms, this is the observational study of the distribution and determinants of health-related states in human populations. We are looking at what is actually happening to real people in the real world. The tools here are study designs like ecological studies, cross-sectional surveys, case control studies, and prospective cohort studies.
And while epidemiology provides our most direct evidence of human impact, it is plagued by severe methodological limitations when applied to environmental exposures. The most glaring issue is that epidemiology is inherently reactive.
Right, it's counting the bodies after they've already floated down the river.
Exactly. You cannot ethically expose a group of humans to a suspected carcinogen just to see what happens.
Yeah.
You have to wait until an exposure has occurred naturally or occupationally and then measure the tragic results.
And beyond being reactive, I imagine the logistical mechanics of tracking these exposures over time are a nightmare.
It is incredibly difficult due to the problem of latency. Many environmental diseases, particularly occupational cancers, have latency periods of decades. Consider a worker exposed to asbestos in a shipyard in 1980. They might not develop mesothelioma until 2010. If an epidemiologist is trying to run a case control study in 2010, taking patients with mesothelioma and comparing them to healthy controls to find the exposure difference, they have to accurately reconstruct the patient's exposure history from 30 years ago.
People move, companies go bankrupt, memories fade, and confounding variables pile up. Did they also smoke? Did they live near a highway? Isolating that single environmental variable over a multi-decade timeline is statistically daunting.
Which is why we also rely heavily on toxicology. If epidemiology is observational and reactive, toxicology is experimental and proactive. It is the controlled study of the adverse effects of chemicals or physical agents on living organisms, usually laboratory animals, in order to predict the potential impact on humans.
The benefit here is obvious, right? We can test a new industrial chemical before it is released into the market. We control the dose, we control the environment, we eliminate the confounding variables, but there has to be a catch.
Oh, there is. The catch is the science of extrapolation, and it is fraught with uncertainty. To get statistically significant results in a toxicological study without waiting the entire lifespan of a rat, researchers frequently expose the animals to very high doses of the chemical over a short period of time.
But that doesn't mirror reality. A human in a city isn't getting a massive acute dose of benzene over 3 weeks. They are getting a microdose of benzene from traffic exhaust every day for 80 years.
Exactly. Translating a high-dose, short-term effect in a rodent into a low-dose, chronic risk in a human involves massive mathematical modeling and biological assumptions. A mouse's liver does not process chemicals exactly the same way a human liver does. Furthermore, toxicology struggles to replicate the synergistic mixtures we talked about earlier. A lab rat is exposed to one pure chemical in a sterile cage. A human is exposed to thousands of interacting chemicals simultaneously.
So if epidemiology is always looking backward through a fog of confounding variables and toxicology is relying on complex interspecies math, how do we ever arrive at a point where a regulatory agency can confidently declare chemical X causes disease Y?
We don't rely on absolute mathematical proof, because in biology, that rarely exists. Instead, we rely on a framework of causal inference. The gold standard for this was outlined in 1965 by Sir Austin Bradford Hill. The Bradford Hill criteria are a set of 9 principles that epidemiologists use to evaluate whether an observed statistical association is likely to be truly causal.
I think we need to do a deep dive into the most critical pillars of the Bradford Hill criteria, because this is how the scientific sausage is made. Let's start with the absolute anchor, the one criterion that is non-negotiable: temporality.
Temporality simply means the exposure must precede the disease. If you are trying to prove that a contaminated municipal water well caused an outbreak of cholera, you must prove that the patients drank from that well before they developed the symptoms.
It sounds so incredibly obvious, but I imagine in chronic environmental diseases, establishing temporality isn't always that clean.
It can be agonizingly difficult. Imagine trying to prove that a specific pesticide causes a slow-developing neurological disorder like Parkinson's disease. If a farmer is diagnosed with Parkinson's and you find high levels of the pesticide in their adipose tissue, can you definitively prove the exposure happened years before the underlying neurological damage began, or did the exposure happen recently, after the disease process had already started? Establishing the exact timeline is paramount.
The next major pillar is biological gradient, which is frequently referred to as the dose-response relationship. This principle states that as the magnitude of the exposure increases, the risk or the severity of the disease should also increase.
Right. If we hypothesize that airborne particulate matter causes asthma exacerbations, we should see higher rates of asthma attacks in neighborhoods with 50 micrograms of PM2.5 compared to neighborhoods with 10 micrograms. If we don't see that gradient, it casts doubt on the causality.
Another crucial criterion is consistency. Does the association hold up under different conditions?
This is vital for ruling out local bias or specific confounding variables. If a team of researchers in London finds a statistical link between a specific food additive and pediatric hyperactivity, that's an association. But if a completely different research team in Tokyo, using a different study design in a different population, finds the exact same link, the consistency of that finding strongly bolsters the argument for true causality.
And we should also mention plausibility. Does this statistical link actually make biological sense based on our current understanding of anatomy and pathophysiology? There has to be a rational mechanism of action. But even if we apply the Bradford Hill criteria perfectly, there are still statistical traps in environmental health that can lead us to entirely wrong conclusions. And this brings us to a concept check that I think is one of the most important takeaways from this chapter: the ecological fallacy.
The ecological fallacy is a pervasive error in logic and epidemiology. It occurs when a researcher or a clinician makes inferences about the specific risk to an individual based solely on aggregated data from the larger group or geographic area to which that individual belongs.
I always try to explain this using a weather app analogy. Let's say you open your phone and your weather app says there is a 100% chance of heavy rain currently falling in your zip code. The ecological fallacy would be assuming that because it is raining in your zip code, you specifically must be getting soaking wet right at this exact moment.
I like that analogy because what is the assumption missing?
It's missing all the individual variables. I might be standing inside my living room. I might be in my car. I might be holding a massive umbrella. Or I might be standing on the one specific street corner where the rain cloud hasn't reached yet. The aggregate data for the zip code, the environment, is accurate, but it tells you absolutely nothing about my personal, individual exposure to the rain.
And translated to public health, applying neighborhood-level environmental data directly to an individual patient's risk profile creates immense false assumptions. Just because a city's air quality monitoring station reads dangerously high for sulfur dioxide doesn't mean every person living within a 5-mile radius is uniformly exposed or exposed at the exact same dose.
They might work indoors in a building with HEPA filtration. They might live on the 20th floor of an apartment building where the pollutant concentration is lower. They might have a genetic resilience.
Precisely. You cannot map population-level aggregate data directly onto individual pathophysiology without accounting for those micro variations. And understanding that gap between the ambient hazard and the environment and the actual dose reaching the individual is the entire basis for the next phase of our work. This brings us to the core operational mechanism of public health, the calculus of protection.
So epidemiology and toxicology have provided us with this data. We've applied the Bradford Hill criteria. We have a strong suspicion that chemical X is harmful. But raw scientific data doesn't protect anyone. How does a government regulatory agency like the EPA in the US or the European Environment Agency actually use this data to create a hard, enforceable legal limit? How do we move from this chemical seems bad to the legal limit in municipal drinking water is exactly 5 parts per billion?
We accomplish that translation through a highly structured decision-making process called the Risk Assessment Framework. In 1983, the U.S. National Research Council, the NRC, published what is affectionately known as the Red Book. It established a four-step framework for risk assessment that has subsequently been adopted as the global gold standard for environmental regulation.
Let's walk through these 4 steps methodically because this is how the shield is built. Step 1 is hazard identification.
Hazard identification is essentially a qualitative yes or no gateway question. Based on the totality of the epidemiological and toxicological evidence, does this specific agent have the intrinsic biological capacity to cause an adverse health effect in humans? Does arsenic cause cancer? Yes. Does lead impair neurodevelopment? Yes. That is hazard identification. It establishes that a threat exists.
Okay, got it. Step 2 gets much more mathematical. It is the dose-response assessment.
Now we're asking for the quantitative relationship. At what specific level of exposure, though dose, do we begin to see adverse health effects? And how rapidly do those effects escalate in severity or frequency as the dose increases? This step involves plotting the data on a curve and trying to identify a threshold, the level below which no adverse effects are observed. For some things, like ionizing radiation or certain carcinogens, we assume there is no safe threshold. Any exposure carries some risk.
Step 3 is where we leave the laboratory and look at the real world. Exposure assessment.
This is often the most difficult step. We have to determine who is actually exposed to this hazard in the real world. What are the specific pathways of exposure? Is the chemical in the air we breathe, the water we drink, or the food we eat? What is the magnitude of the exposure? How many hours a day does it occur? And when does it happen during a person's lifespan? We have to define the specific population at risk, accounting for vulnerable groups like children or occupational workers.
And finally, we arrive at step 4. Risk characterization. This is the grand synthesis.
Exactly. We take the qualitative hazard identified in step 1, we map it onto the quantitative dose-response curve from step 2, and we apply that math to the real-world exposure scenarios developed in step 3. The output is an estimation of the actual probability and magnitude of harm that will occur in the defined population. This final characterization is what policymakers use to decide if a regulation is necessary and what the legal limit should be.
Now, to fully understand this framework, we have to pause and explicitly define 2 terms that are thrown around interchangeably in the media and by the public, but in environmental health practice, they are entirely distinct concepts: hazard versus risk.
Conflating these 2 terms is the source of endless regulatory confusion and public panic. They are not the same thing.
I find the best way to explain this differentiation is the shark analogy. Think of a massive great white shark. That shark is a hazard. By its very biological nature, its teeth, its jaw strength, it possesses the intrinsic potential to cause you severe harm. That intrinsic property cannot be changed. However, if that great white shark is swimming in the middle of the Pacific Ocean and you're currently sitting safely inside a locked farmhouse in the middle of Kansas, your risk of a shark attack is absolute 0.
That perfectly captures the mathematical relationship. Risk requires the hazard plus the exposure. You only have a risk if you physically get into the ocean with the hazard.
So hazard is an intrinsic property of a substance or agent. Risk is the statistical probability of harm actually occurring under specific exposure conditions.
And from a regulatory standpoint, this is crucial because we cannot always eliminate the hazard. Industrial chemicals are hazards, but they are necessary for modern manufacturing. X-ray machines are radiation hazards, but they are necessary for medical diagnostics. The goal of environmental health practice is rarely the complete elimination of all hazards, which is impossible, but rather the management and minimization of risk by strictly controlling the human exposure.
But to control that exposure, we need a way to constantly monitor it. We need a radar system that tells us if the exposure is creeping up before people start arriving in the emergency room. And that brings us to Section 5, surveillance, monitoring, and indicators. To continuously run those complex risk assessments and protect the public, we need a constant stream of reliable data.
Which is why surveillance is the bedrock of operational public health. The textbook defines surveillance as the ongoing systematic collection, analysis, and interpretation of health data, perfectly integrated with the timely dissemination of that data to those who need it to take action. We are talking about vast data networks like Poison Control Center hotlines, congenital birth defect registries, and national biological monitoring programs.
And the textbook highlights one of the most triumphant success stories of environmental surveillance in modern history: the CDC's blood lead monitoring program in the United States during the late 20th century.
It is a phenomenal example of data defeating entrenched industrial interests. For decades, the automotive and chemical industries fought vehemently to keep tetraethyl lead in gasoline. They argued that the lead coming out of tailpipes dispersed harmlessly and did not pose a significant threat to human biology. And without population-level data, it was a difficult argument to definitively refute.
But the CDC had established the NADS program, the National Health and Nutrition Examination Survey, which systematically collected blood samples from a representative cross-section of the American public year after year.
And that surveillance data was a smoking gun. As the EPA began to implement phased regulations slowly reducing the amount of lead allowed in gasoline, the CDC's surveillance data showed a direct, mirroring, near immediate drop in the average blood lead levels of the U.S. population.
Wow.
Yeah, the two curves mapped onto each other perfectly. It proved causality in real time on a population scale. That undeniable surveillance data provided the political and scientific ammunition required to drive the final regulatory policies to ban lead in fuel completely.
It is the ultimate proof of concept for surveillance. But having millions of raw data points on a spreadsheet isn't particularly helpful for a mayor or a policymaker trying to understand the health of their city. We have to distill that raw data into actionable snapshots. We call these indicators.
Indicators are vital communication tools. They allow us to see the big picture by tracking a small, carefully chosen metric, and we categorize them based on what we need them to tell us.
Let's walk through the types. First, we have descriptive indicators. These are used to establish a baseline reality of what is happening right now. For example, the infant mortality rate of a specific region, or the daily ambient concentration of ozone in a city's air. It just describes the current state.
Then we have performance indicators. These are highly specific and are directly linked to a predefined policy target. They measure how well a government or agency is doing its job. An example would be the percentage of the municipal population that has access to safely managed drinking water, or the percentage of local food establishments that have undergone a sanitary inspection in the last 12 months. It measures action.
And finally, we have composite indicators. These are fascinating because they attempt to condense a massive array of complex, disparate information into a single, easily digestible index number.
The Disability Adjusted Life Year, or DALY, is the classic metric used in global public health. It attempts to quantify the true burden of disease by combining the years of life lost due to premature mortality with the years of healthy life lost due to living with a disability or disease. Another prominent example is the Human Development Index, the HDI, which combines national life expectancy, educational attainment, and per capita income.
They are incredibly useful for comparing the overall progress of different countries, but they require complex statistical weighting, which means they can sometimes obscure the specific localized problems we discussed earlier. Now, to make all these different indicators truly useful for designing an intervention, we need a logical framework to organize them. And the World Health Organization utilizes a very specific causal framework called the DPEEA model, DPSEA. It stands for driving force, pressure, state, exposure, effect, and action.
The DPCO model is brilliant because it maps out the entire chronological chain of an environmental health issue, from the macroeconomic origins all the way down to the clinical outcome. Let's walk through the model sequentially, using a tangible example like the urban air pollution we discussed during the double burden.
Okay, the process always starts at the top with a broad macro-level driving force. In our urban example, the driving force would be rapid economic development, industrialization, and massive population migration into the city.
That macro driving force inevitably creates a specific pressure on the physical environment. Because there are 1 million new residents in a booming economy, there's a massive increase in commercial traffic volume, diesel freight transport, and industrial factory emissions. That is the pressure.
That sustained pressure then alters the state of the environment. The state of the ambient air quality in the city becomes severely degraded. The air is now physically filled with high concentrations of particulate matter like PM2.5.
Then we cross the threshold into human contact. Exposure. Because the state of the air is degraded, the citizens living and working in that city are exposed. They are breathing in that PM2.5 deep into their lungs every single day.
And that exposure leads directly to a clinical effect. We begin to see epidemiological spikes in pediatric asthma admissions at the local emergency rooms and long-term increases in chronic obstructive pulmonary disease and cardiovascular events.
And this leads to the final and most crucial component of the model, action. The true value of the DPCE framework is that it reveals all the potential intervention points for an environmental health practitioner. You don't have to wait until the effect stage to act.
Right. You could implement an action at the driving force level by redesigning the city's urban planning and zoning laws. You could target the pressure by enforcing stricter tailpipe emission standards for diesel trucks. You could target the state by creating pedestrian-only clean air zones in the city center. Or you could target the effect by improving the distribution of prophylactic asthma inhalers at local clinics.
Exactly. It provides a menu of systemic interventions. But to intervene effectively, particularly at the state and exposure levels, you need highly accurate, granular data about where the pollution actually is. And here we must make a very strict differentiation between two types of environmental monitoring that are often confused: compliance-oriented monitoring versus true health exposure monitoring.
This is a huge point of friction between environmental agencies and public health departments. Why can't the health department just use the data from the compliance monitors? The sensors that the EPA makes the factory install directly inside their smokestack to prove they aren't breaking the legal emissions limit. Isn't that data sufficient to calculate the public's risk?
It is entirely insufficient for public health purposes, and understanding why requires understanding the physics of pollution dispersal. Compliance monitoring is designed for a very specific legal purpose: to check if a specific source like a factory smokestack or a wastewater discharge pipe has crossed a legally mandated threshold at the exact point of emission. It is measuring peak output for regulatory enforcement.
But the pollutant concentration doesn't stay static. It changes the millisecond it leaves the smokestack.
Exactly. Pollutants disperse based on wind patterns, thermal inversions, and topography. They have immense spatial and vertical variations. The concentration of a chemical drops sharply as you move away from the source horizontally, or as you move higher up in a high-rise building vertically. A compliance monitor sitting inside a smokestack tells you precisely what the factory is doing. It tells you absolutely nothing about the actual diluted dose reaching the lungs of a child playing in a park 3 miles downwind.
Oh, wow.
Yeah. To calculate risk, surveillance must measure actual human exposure in the brief zone, not just legal compliance at the source.
Which perfectly sets up the transition to Section 6, upstream interventions and global governance. Once our radar networks detect a threat, and we've modeled the risk, and we understand the exposure pathways, how do we actually engineer the system to prevent it from happening again? We need to look at the predictive policy tools and the global boardrooms where these massive architectural decisions are made. And the ultimate tool for predictive upstream engineering is the Health Impact Assessment, or HIA.
An HIA is a systematic decision support tool used to predict the potential downstream health outcomes of a planned policy, program, or massive infrastructure development project before it is ever built or implemented. It is the attempt to look into the future and measure the invisible.
Let's walk through a hypothetical to see how an HIA actually functions. Imagine a city government wants to build a massive new 6-lane elevated highway directly through a dense, lower-income residential neighborhood. If they perform an HIA, they aren't just looking at the traffic flow.
No, the HIA attempts to holistically calculate how that specific infrastructure will impact human biology and psychology. Will the highway increase local asthma rates due to the new concentration of diesel particulate matter? Will it lead to an increase in pedestrian traffic injuries? How will the constant high-decibel traffic noise affect the cortisol levels and sleep quality of the residents?
Right.
Will the physical barrier of the highway destroy the social cohesion of the neighborhood, leading to increased isolation and depression?
The steps for conducting an HIA are standardized. Screening to determine if the project warrants an HIA. Scoping to decide exactly which health impacts to investigate. Assessing the magnitude and direction of those potential impacts. Reporting the findings to the policymakers. And finally, evaluating the process. But here is the incredibly frustrating reality that the text points out. Despite how logical and necessary an HIA sounds, they are vastly underutilized, especially when compared to their older sibling, the Environmental Impact Assessment, or EIA.
Environmental impact assessments have been a legal requirement in many nations for decades, stemming from legislation like the National Environmental Policy Act of 1969 in the U.S. If you want to build a hydroelectric dam, you are legally required to conduct an EIA to determine how the construction will affect the local wetland hydrology or the breeding patterns of a specific endangered frog.
Right.
And yet, legally mandating an assessment of how that same project holistically affects human health is still relatively rare.
Why is that? Why is it easier to protect the frog than the human population?
It comes down to the bureaucratic nightmare of enforcing a health in all policies approach.
Ah.
Conducting a true HIA requires public health officials to insert themselves into government sectors that are completely unaccustomed to considering health metrics, like the Department of Transportation, the Zoning Board, or the Energy Commission.
Which they probably don't love.
Not at all. Furthermore, assessing the impact on a frog habitat is methodologically simpler than predicting how a new zoning law will alter a community's traditional dietary habits or rates of domestic violence. The causal pathways for human social health are incredibly complex, and demanding that a highway planner account for neighborhood depression rates is politically and methodologically fraught.
So the predictive tools are struggling against local bureaucratic silos, but what about the macroscopic level? Environmental threats don't respect municipal borders, which is why we have seen a massive evolution in global environmental governance over the last 60 years. The text traces this modern environmental awakening back to Rachel Carson's seminal book, Silent Spring, published in 1962, which violently sounded the alarm on the ecological and human health impacts of the indiscriminate use of synthetic pesticides like DDT.
Carson's work proved that human ingenuity could inadvertently poison the entire biosphere. And that realization catalyzed a series of major global milestones. A key turning point was the 1987 Brundtland Commission, which formalized the modern concept of sustainable development. They defined it as development that meets the needs of the present without compromising the ability of future generations to meet their own needs.
Which introduced the concept of the triple bottom line. The idea that true, sustainable progress must equally balance environmental protection, social equity, and economic growth. You cannot sacrifice the respiratory health of a population for a short-term boost in industrial GDP. But conversely, you cannot mandate draconian environmental protections that plunge developing populations into immediate economic starvation. It requires an incredibly delicate, negotiated balance.
And the attempt to formalize that balance culminated in the 1992 Earth Summit, the UN Conference on Environment and Development in Rio de Janeiro. This was a watershed moment in global governance. It produced Agenda 21, a comprehensive blueprint for global action, and critically, the Rio Declaration, which enshrined several foundational guiding principles of environmental health policy that are still fiercely debated today.
Let's clearly define two of the most consequential principles from the Rio Declaration. The first is the precautionary principle. This is a massive philosophical shift.
The precautionary principle states that where there are threats of serious or irreversible damage to the environment or human health, a lack of full scientific certainty shall not be used as a reason for postponing cost-effective measures to prevent that degradation.
To put that in the context of our Bradford Hill discussion earlier, it means you do not have to wait decades for the absolute, final, undeniable epidemiological proof of causality if the potential harm of waiting is catastrophic. You act preemptively to protect the public based on strong indicative evidence. But I imagine industry hates this principle.
Oh, they often fight it fiercely. They argue that it stifles economic innovation and leads to costly regulations based on theoretical fears rather than hard data. But from a public health perspective, it is the ultimate upstream defense.
The second major concept is the polluter pays principle. This is an economic corrective. It simply states that the entity that causes the pollution, the factory, the corporation, should bear the total financial cost of cleaning it up and managing the health impacts, rather than externalizing that massive cost onto the taxpayers or the public healthcare system.
The Rio Summit laid the groundwork and was followed by the World Summit on Sustainable Development in Johannesburg in 2002, which pivoted to focus heavily on the immediate health crises of water and sanitation in the developing world.
But I have to offer some serious pushback here, because this is where the soaring textbook theory of global governance violently collides with the harsh reality on the ground. We have just discussed decades of massive global summits, Rio, Johannesburg, Kyoto protocols, thousands of international delegates, binding treaties, and lofty declarations about the triple bottom line. And yet, as we established in our discussion of the double burden, the text clearly states that right now, today, over 1 billion human beings are still forced to practice open defecation.
Yes.
Millions of children are still dying from preventable, environmentally driven diarrhea and pneumonia. If we have all these global frameworks, where's the catastrophic disconnect? Why aren't these treaties fixing the plumbing in the slums?
It is the great frustration of global public health. The disconnect lies in the immense jurisdictional, financial, and structural barriers to implementing what the WHO calls Intersectoral Action for Health, or IAH. A global treaty negotiated in Switzerland is merely a declaration of intent, but the actual physical work of building a municipal sewer system, enforcing a clean air zone against a powerful local trucking union, or inspecting thousands of food stalls requires a functioning local government, an adequate municipal tax base, and fierce political will at the city level.
An international treaty on sustainable development does not magically manifest a water treatment plant in a rapidly expanding informal settlement in Lagos.
Exactly. Furthermore, international environmental agreements inherently respect national sovereignty. They can suggest targets, but they rarely have the teeth to dictate domestic municipal policy. The global governance boardrooms can establish the destination, but it is the local practitioners on the ground who have to figure out how to navigate the mud to get there.
Which serves as the perfect transition to our final area of focus. Section 7, Operational Public Health. Because all the complex epidemiological modeling, all the precise toxicological risk assessments, and all the grand global treaties mean absolutely nothing without boots on the ground to enforce them. We have to conclude by looking at the practitioners, the people who actually build and maintain the structural shield.
The frontline troops of this discipline are the environmental health officers, or EOs. As we discussed, their lineage traces directly back to Chadwick's 1848 inspectors of nuisances. But today, they are highly trained, multidisciplinary professionals, sanitarians, environmental scientists, public health officers. They're the ones actually managing the vast, unglamorous array of local issues that keep a city alive.
Right.
Enforcing housing quality standards, conducting rigorous food safety inspections in restaurant kitchens, managing complex vector control programs to suppress mosquito and rodent populations, and responding to local hazardous material spills.
But the textbook makes a very pointed argument that the responsibility doesn't end with the EOs. The practicing clinician, the physician, the nurse practitioner has a vital, non-negotiable role in this system. The text insists that clinicians must evolve beyond the rescue reflex. It is no longer acceptable to simply prescribe a corticosteroid inhaler for a pediatric asthma patient, discharge them, and send them right back into the mold-infested apartment or the diesel-choked neighborhood that triggered the severe exacerbation in the first place. Clinicians must be trained to take a rigorous, comprehensive environmental history.
And that requires cultivating what we call a high index of suspicion. When a patient presents with a pathology, the clinician's diagnostic algorithm must expand outward. They should routinely be asking, what is your exact occupation? What specific chemicals do you handle at work? What are your hobbies? What year was your home built? And is there peeling paint or chronic dampness? Do you rely on well water or municipal water? What kind of fuel do you use for heating and cooking? It is the practice of integrating the patient's macro environment directly into the microdiagnostic workup.
But structurally, attempting to practice this kind of holistic, systemic medicine is a jurisdictional nightmare. And the textbook highlights a fascinating piece of bureaucratic history that explains why. It details how the profound jurisdictional silos that currently fracture environmental health practice came to be.
It's a critical piece of the puzzle. Historically, dating back to the late 19th and early 20th centuries, the local municipal health department was the centralized authority for almost everything. They managed infectious disease outbreaks, basic sanitation, water quality, and food safety all under one roof.
But then the environmental awakening of the 1960s and 70s happened.
Right. As the public demanded action on massive ecological crises, governments responded by passing incredibly complex, medium-specific environmental laws, the Clean Air Act, the Clean Water Act, and creating massive new federal agencies like the EPA in the United States to enforce them. But in doing so, they essentially carved the discipline of environmental health out of the traditional public health departments.
So the focus shifted away from holistic human health and toward medium-specific ecological protection.
Yes. The unintended consequence was a severe fracturing of responsibility. So today, if a patient is sickened by their environment, the ambient air quality might be regulated by a state environmental protection agency. The safety of their food might be managed by a federal agricultural department. The mold in their apartment might fall under the jurisdiction of a municipal housing or zoning board, and the epidemiological tracking of their disease is left to the local health department.
It is a recipe for catastrophic communication failures. It's like having one mechanic solely responsible for the engine, one mechanic solely responsible for the tires, and one mechanic solely responsible for the brakes, but none of them are legally allowed to speak to each other while the car is careening down the highway at 80 miles an hour. These bureaucratic silos inherently prevent a holistic view of the patient's actual cumulative exposure.
which is precisely why the Institute of Medicine, the IOM, published a critical report recommending a minimum package of public health services. They argued that regardless of how fractured a government's bureaucratic structure is, every single public health department must possess fundamental, cross-cutting capabilities. They must have robust surveillance epidemiology, advanced policy analysis skills, and the capacity for aggressive cross-sector communication. Without those foundational capabilities, a health department cannot successfully navigate across the silos of the EPA, the Housing Board, and the Agricultural Department to advocate for the public.
And when you understand that fractured system, you understand why the clinician's index of suspicion is the ultimate, and sometimes the only, safety net. When the environmental agencies and the zoning boards fail to communicate and the data falls through the cracks, it is the solitary doctor or nurse taking a careful, deliberate environmental history in the exam room who finally connects the dots for the patient sitting in front of them. It requires a profound commitment to systems thinking.
Systems thinking is the true essence, the absolute core of environmental health practice. It is the hard-won understanding that the weeping child in the emergency room, the diesel freight truck idling outside their bedroom window, the municipal zoning laws that allowed the trucking depot to be built next to a residential neighborhood, and the global economic forces demanding faster freight delivery are all intimately, inextricably connected by a single line of causality. You cannot treat the child without addressing the truck, the law, and the economy.
Which leaves us with a deeply provocative thought to close out this deep dive. We have spent this entire session discussing how protection depends entirely on accurate measurement and how that measurement demands absolute scientific and political integrity. But as we move deeper into the 21st century, we are entering an era of entirely novel systemic exposures threats that are evolving faster than our regulatory frameworks can adapt. Think about the pervasive infiltration of microplastics, now being discovered crossing the human blood-brain barrier and embedded in placental tissue. Or consider how complex algorithmic digital environments are fundamentally altering our social and psychosocial health, demonstrably changing pediatric neurochemistry, driving population-level anxiety, and altering sleep architecture. How will the next generation of environmental health practitioners and epidemiologists define an exposure or calculate a dose-response curve when the environment itself, both the invisible physical particulate and the omnipresent digital architecture, is fundamentally altering human biology from the inside out? How do you build an upstream structural barrier when the stream is literally everywhere?
That is the defining existential challenge for the next era of public health. We have mastered the sanitation of water. We now have to master the sanitation of complex systems.
It's definitely something to seriously mull over as you encounter these pathologies in the clinic. Okay, before we completely wrap up, it is time for our learning reinforcement. Let's do a quick knowledge check with 5 rapid single best answer prompts based on the core concepts of today's deep dive. I'll read the question, pause briefly, and then provide the answer. Question 1. Within the 1983 National Research Council framework, which specific step directly calculates the quantitative mathematical relationship between the magnitude of the exposure and the resulting severity or frequency of the disease?
Pause.
The answer is the dose-response assessment. If you need to consolidate your understanding of how hazard translates to risk, revisit the risk assessment framework section of the text. Question 2. According to the DPS-EA model, a measurable increase in pediatric asthma emergency admissions due to severely degraded ambient air quality falls under which specific category of the framework? The answer is effect. Review the indicator framework section for more details on mapping the causal chain. Question 3. Which foundational policy principle, enshrined in the 1992 Rio Declaration, explicitly states that a lack of full scientific certainty should not be used as a reason to postpone cost-effective measures to prevent serious or irreversible environmental degradation?
Pause.
The answer is the precautionary principle. This concept is thoroughly covered in the Environmental Health Policy and Global Governance section. Question 4. Beyond behavioral factors, what is a primary physiological mechanism that makes young children significantly more vulnerable to environmental toxins than adults exposed to the exact same environment? The answer is a higher metabolic rate leading to a vastly increased minute ventilation and intake of contaminants relative to their body weight, combined with immature physiological detoxification pathways, such as developing hepatic enzymes and a more permeable blood-brain barrier. Check the vulnerable group section to consolidate these pharmacokinetic concepts. And finally, question 5. Attempting to systematically predict the holistic health outcomes, including respiratory, traumatic, and social impacts of a newly proposed urban highway infrastructure project before the construction begins, is an example of what specific predictive process. The answer is a health impact assessment, or HIA. Revisit the Environmental Health Impact Assessment section to understand how it differs from a standard environmental impact assessment. I highly encourage you to read Chapter 11.5 of the Oxford Textbook of Global Public Health alongside this deep dive to fully consolidate these frameworks and historical contexts. Remember, as clinicians and public health practitioners, the goal isn't just to repeatedly pull exhausted people out of the river, it's to walk upstream, find out who's throwing them in, and engineer a system that stops them. Here are the details of this episode. GPH 101, Environmental Health Practice.